my slides going. Okay. Yeah, really excited to be giving this talk. So thank you so much, Rena, for this opportunity. The title of my presentation is Allowing Failure as a Clinical Teaching Strategy. And, I included this framed picture, which is in my office, because every year my wife, who's also a pediatric hospitalist, and I host a party for our graduating residents at our home. And we both mentor quite a few residents in our program, and I think this picture is such a good reminder that teaching, and especially if you're thinking about using failure as a tool for growth, only works if it's grounded in strong, trusting relationships or a good educational alliance. Without that foundation, I think failure uh, typically feels more threatening instead of supportive. So I'm going to be coming back to this theme about the importance of relationships um, as you're thinking about using failure as a clinical teaching strategy. Okay, so I have no disclosures today, and here are my learning objectives. So at the end of this talk, and I don't have 55 minutes of slides. I have a couple embedded questions, reflection questions for the group, but I promise we'll hopefully be able to end a little early. But at the end of this presentation, I hope you'll be able to describe some of the benefits of allowing your trainees to fail, and hopefully you'll have learned a couple strategies that you can incorporate in your clinical settings to maximize the benefit and minimize the harms when allowing trainees to fail. I did want to give a couple acknowledgments. So at the AAMI conference in Barcelona last summer, I was part of a fantastic group where we gave a workshop on allowing failure as a teaching strategy. And I want to acknowledge my co-presenters for that talk, Leo Aliaga, Jen Clausen, and Naomi Steamhoff. Some of the content and slides were adapted from that workshop that we gave at AAMI. All right, so let's get going here then. So I think it goes without saying that we all make mistakes and fail. And in the famous book entitled "Complications" by Atul Gawande, he says virtually everyone who cares for hospital patients will make serious mistakes. And for this reason, doctors are seldom outraged when the press reports yet another medical horror story. They usually have a different reaction. That could be me. And perhaps failure is necessary. This quote is from another well-known book, How Doctors Think. And in it, Dr. Grubman wrote, different doctors achieve competency in remarkably similar ways, despite working in disparate fields. Primarily, they recognize and remember their mistakes and misjudgments and incorporate those memories into their thinking. Now, compared to other industries where failure is sometimes embraced and encouraged, in medicine, failure truly is the F word. And I do want to call out that we're dealing with people's lives. We're not making watches or iPhones, so yes, it is different. But I think there are quite a few studies, even in the health professions education literature, that shows that there is value in making mistakes and failing. Now, back in 2006, Manu Kapoor first explored this concept of failure as a learning mechanism in his doctoral work. And he's published a lot on this. And if you do a PubMed search of the idea or concept of productive failure, you will find hundreds and hundreds and hundreds of citations. And even pre-Kapoor, the idea of error management originated in organizational psychology. So in the early 2000s, managers were using errors to help train their employees. And even before that, so in the 1990s, the idea of desirable difficulties was coined by people like Janet Metcalf and Dan Schwartz and Dr. Elizabeth and Dr. Robert Bork from UCLA. So this idea of using failure and mistakes to enhance learning has been around for quite some time, actually. And if you look at some of the reviews and sort of the summary articles on all that literature, whether it's error management, desirable difficulties, about Kapoor's work, I think some of the take-home messages is that failure generation results in better later retrieval of the correct response than error-free study. But one of the key components of this sort of tool or strategy is that the learning benefit is greatest with the right feedback. In other words, at the end of the experiment, the assignment, um, it's really important for the supervisor, or in our case, the attending, explains the correct reasoning to close the loop. So here is sort of what I call an interactive activity, or maybe an icebreaker. Although I know for you it's 3 hours ahead, so it's the afternoon, not the morning. But I wanted you all to take a few seconds to just reflect and to potentially think about a time when one of your learners, or potentially you, benefited from failure. And as sort of extra credit or a bonus question, think about what factors do you think contributed to that positive learning outcome? And I was hoping that there might be one or two brave souls out there who'd be willing to unmute, raise their hand, and potentially share with the group a time when a learner or themselves benefited from a failure. I certainly have a lot of examples myself.
And Jimmy, I can call on a person while if they put their hand up, so don't worry about that.
Okay, sure. Yeah, you probably know these folks well, so you can call on somebody if you want. Or and I believe the chat box is not active either, correct? So
Yeah, we're gonna have
hopefully,
people speak. Well, Adam, please go ahead.
great.
Sure. It's pretty easy. I'm an anesthesiologist, Jimmy, and been playing in simulations. We use simulation for failure all the time. But in the OR, there's always a missed airway and a difficult, unrecognized airway. And the ability to work through that missed airway, the difficult airway, the failed airway, is really influential. And in fact, it happens not infrequently where our plan was to manage one airway or manage the patient in one capacity, find that that device led to failure, using another device to try to rectify it, and further failure, and then debriefing and recognizing what we ultimately ended up doing. And as I was, applauding the resident, and things sort of went sideways, I'm like, look what we gained from the experience. If the airway went in uneventfully, or the intubation was uneventful, we wouldn't have gained all the benefits of safely managing the patient, reflecting on what we did, how we can improve our performance. And unfortunately, we're going to have these cases happen all the time. And what we did do well was we kept our cool. We thought about the next three events from the time that we were managing the patient. We kept the patient stable. We communicated well to everyone, and the team worked very effectively. So, I look at failure or imperfection as the perfect opportunity to teach. So I really applaud this lecture. So thank you.
Thanks, Adam, for sharing that example. I'm a pediatric hospitalist, and so we typically don't deal with super acute patients. And so I really like your example. As an anesthesiologist or surgeon, maybe an intensivist, you will probably encounter more sort of tenuous situations. So I loved how you share that example of being able to do this effectively, but also safely for the patient that was involved. So thank you. Great. My next reflection activity has to do with intentionality. And this one is a little bit trickier, but has anyone intentionally allowed one of their learners to fail, and is willing to share an example of how that went? So again, an intentional allowance of failure. Anybody want to share an example here?
Go ahead, Margie. Go ahead.
So when the stakes are low enough, right? Because I'm a rheumatologist, adult
Okay.
rheumatologist. So the joke in our field is that, how much steroid should we give? And the answer is enough, but not too much. So I like to help the fellows understand the potency of the drug and, you know, what they can hope to achieve and the risk benefit and all that. And so I let them kind of, if I see that they're going to underdose or overdose a little bit, but the risk to the patient is not great. There is going to be a way to rescue. There won't be permanent harm, but I let them do their thing so that they can really understand the consequences of, and I don't want to just spoon feed them the whole information. I want them to see what happens when they make decisions. So we are, you know, we're giving them graded responsibility, and sometimes I let them stumble a little bit just to drive the lesson home. And I think they understand it better after they see the outcome of their own action. They made the decision, they see the outcome, but they are getting my support, and no great harm will come to the patient. So I don't know. That's just one example. It's low stakes, but I think it's better for their learning overall.
Yeah, thank you for sharing that example. I think you said a lot of great things there in terms of letting them see the outcome of their decision, so providing that autonomy, and then not resulting in permanent harm, because there is a balance, right? I think, first and foremost, we are, we have an obligation to the patients, but in a little bit, I'm going to talk about the obligation to our trainees' future patients. What obligations do we have for those? So I think there is that balance. So thank you for sharing that example. Does anybody else want to share any other examples before I move on, either for an intentionally allowed failure or just how they maybe benefited from a failure in the past? Okay, well, let me share an example of how I oftentimes allow failure. I oftentimes let my residents and fellows, not so much students, because I don't tend to have as long-standing relationships with them, but I allow my residents and fellows to call subspecialty consultations like nephrology, cardiology. And I do this even though I know that consultants um, can be sometimes blunt or question why we're consulting them. And my reasoning is that this gives trainees a chance to practice not just getting recommendations, but also navigating challenging conversations. It can be uncomfortable, even stressful at times. But I think that's what real practice is like. That's what being attending is like. I just experienced this a few weeks ago. I called a consult. I was on overnight. I wasn't fully prepared. I didn't know the patient quite as well as I should have. And it was a humbling reminder. And I think the key is what happens afterwards. Adam talked about this in terms of the debrief. And I think it's always important to have some sort of debrief. And I'll go back in the afternoon after noon conference, after they've had lunch, and I'll ask them, how did your conversation with Dr. So-and-so go? And if they say, oh, Dr. Smith was nice, he walked me through the differential, I'll actually feel a little disappointed, because there probably wasn't much to learn from that, because they were probably spoon-fed the assessment and plan. I prefer when they say, that was a really tough conversation. They didn't think we had a legit question. And then I follow it up with, knowing what you know now, would you do anything differently? Would you still order the consult? And I think this reflection helps the learners, critically think about their decisions and learn from the experience, especially when things don't go perfectly right. And my overarching, not moral failure compass, but just sort of my overarching failure compass is, I always ask myself this question: can I reverse the error in a timely manner that will prevent patient harm? Again, in most cases, as a pediatric hospitalist, the failures that I see can be reversed in a timely manner that avoids significant, irreversible, or permanent harm, like was just discussed. And I think it's important to differentiate allowing failures versus allowing flexibility. And I think both are important. So providing autonomy, giving trainees some power in making decisions. Like, for example, if they want to get a repeat electrolyte at 8 p.m., where I probably would have waited till 8 a.m. If they want to do 3 days of antibiotics, maybe I would have done 5. I think that's okay. But that's not really a failure. That's just the gray of medicine. And so I think, again, what we're really talking about is a failure, a mistake, an error, which can be a potent learning experience for our trainees. Now, if failures are such great teachers, why is it so hard to use failures in health professions education? Why aren't more people doing this? I think there's a lot of landmines and barriers and disincentive to doing this, and it takes time. It's hard to do. Like I mentioned at the beginning of my presentation, I think foundational to all of this is the relationship between the supervisor and the trainee. I think there's a lot of literature on burnout and shaming, humiliation, and education. And I think those topics are really important. And so I think creating that environment, that trusting relationship between a supervisor and a trainee is so critical. People have been using the word safety a lot in health professions education, psychological safety, identity safety. And I wanted to take another moment to sort of pause and ask the group, when you hear that term, safety, what comes to mind? How do you define safety in health professions education? What do you think is a safe learning environment for learners? I don't know if we have any learners on this grand round, but that would be great too. But yeah, does anybody want to take a stab or explain to the group how they conceptualize safety in medical education? And I'll preface it by saying there isn't a great consensus definition in health professions education, which is slightly problematic.
Go ahead, Lauren.
Hi, thanks so much. I'm thinking that you're talking sort of along the lines of psychological safety, but obviously there's other types of safety too. So this is like one of my favorite topics, and I would say that, there's learners need to feel like they can express their ideas, even if they're wrong. And not be afraid that they will be yelled at or chastised. And they also have to recognize that we have high expectations of them, that we want them to succeed, that we want them to do better. And it doesn't mean they can't say the wrong answer, but it means that we also, on the flip side of it, is we also have to be able to give them feedback, right? So it can't be so safe that like they could say anything and we're not like correcting them. But it has to be safe that they can share and then understand that we're going to tell them, yes, that's right, or no, or tell me more, right? So that there's exploration of answers. And then there's a ton of other things, right? Like we want to be inclusive, we want to be good listeners, we want to, when people are messaging us, about something that went wrong, we want to be able to say, thank you for sharing that, right? Because otherwise they might be afraid to tell us again when something goes wrong. So that's my conceptualization of it.
Yeah, thanks, Lauren. Sounds like you've done research in this or think about this a lot, because I think a lot of what you said resonates with how I conceptualize safety, in that people feel safe to speak up without fear of negative evals, but also that it doesn't mean lowering standards. It doesn't mean there can't be honest, constructive feedback, or it doesn't mean that we're going to coddle our learners. So I love that. I saw somebody else raise their hand. I'm not sure.
Yes, Sakshi, go ahead.
Oh.
Hi. So Jimmy, when I think of safety in healthcare teams, I think of it as that traditional definition of interpersonal risk taking, that the team members feel safe with interpersonal risk and that failures are tolerated.
Mm-hmm. Yeah, wonderful. I think you're referencing Amy Edmondson's work, right? A shared belief that it's safe to take interpersonal risk without negative ramifications. I think her definition from sort of this text, The Fearless Organization, gets cited a lot. And I think that definition does make sense. I think in health professions education, there's been this slippery slope where safety has been conflated with safety with uncertainty, complete lack of discomfort, challenge, and stress, a catch-all solution for a wide range of problems. I review for a lot of journals and health professions, education journals, meta journals, and I feel as though every discussion over the past couple of years has laid out a problem, an intervention. And in the discussion, they say, and the solution to this all is we just need to create psychological safety for our learners, which it's yes and, right? It's easier said than done. I think the other challenge that I have with safety being thrown around is it's kind of viewed as this achievable endpoint instead of what I think is more of a ongoing process or partnership between team members. And I think it's also been conflated with this idea that attendings or supervisors have this superhuman power to make it safe to achieve for all learners, despite all of our learners having different identities and conceptualizations of safety themselves. And so I think that's another challenge. And again, getting back to one of the themes, right? This is one of my favorite quotes: to make a difference in someone's life, you don't have to be brilliant, rich, beautiful, even perfect. You just have to care. You have to show the trainees that you're not trying to get them, that you're trying to actually help them grow professionally and personally. And Serena said, I'm a huge Duke fan. This is a quote from the former basketball coach for Duke. A common mistake among those who work in sport is spending a disproportionate amount of time on X's and O's as compared to time spent learning about people. And I think the same can be said in medical education. I'll also call out the fact that this is hard, that time is a precious commodity as a supervisor, as an attending. We have so many obligations in addition to our learners. I know in our institution, we recently went to the X+Y format. There's a lot of discontinuity. I used to get to work with trainees multiple times over the course of the 3-year residency program. Now, I hardly get to work with them even one time over their 3-year period. So I think this is hard to do, but I think it's definitely worth spending time to get to know our learners. So to me, safety, it's about the relationship, right? If one of my trainees says, Jimmy truly cares about my professional and personal growth and has my back, I feel as though that is how I conceptualize that there's going to be safety, and then I might be able to use failure as a teaching tool, teaching strategy with that learner. Okay, so I'm going to transition now to talking about a study that I did a couple years ago, in which we explored if and when and how pediatric hospice attendings allow trainees to fail as an educational strategy. And I wanted to acknowledge my co-collaborators on that project, Dr. Jennifer Clausen, Cameron Randall, and Lorelei Lingard. Dr. Clausen actually was the person who I owe a lot of credit. I read one of her papers. She got her PhD through the University of Maastricht in this topic. And I read one of her articles, I think back in 2017, 2018, and I reached out to her, just a cold email. I said, hey, would love to talk. We're going to be doing your article at Journal Club. And we connected and we collaborated, and this was a result of that study. She did a similar study with adult providers. I think she interviewed 18 or 19 adult providers and 2 pediatricians. And all of the adult attendings shared stories of using failure, but there were 2 pediatricians in her cohort who didn't. And so we wanted to explore that in pediatrics. And so we used constructivist grounded theory methodology. We interviewed pediatric hospice from Seattle Children's, and consistent with constructivist grounded theory, we did constant comparison to do our data analysis. And so this was the definition of allowing failure. And this is something that she developed, I think, in study 2 of her doctoral dissertation. And I'll quickly read it. So while supervising a trainee's clinical performance, the supervisor, influenced by both intuition and a complex interplay of 4 factors, detects an immediate trainee mistake, has the opportunity to intervene, but deliberately chooses not to do so because the educational gain for the trainee is perceived to outweigh the potential consequences for the patient. And in our interview guide, we shared that definition at the beginning of all our interviews with our participants. So in total, we had 21 attendings. Most were 6 to 15 years out from their own training. So accordingly, most were either assistant or associate professors. And in our cohort, 19 of the 21 attendings shared at least one, usually more stories of intentionally allowing their trainees to fail as a teaching strategies. And most acknowledge the tension between potential harm to the current patients and trainee wellness versus the educational benefits of the strategy, namely ensuring that the residents who graduated from our program became attendings who were competent, who could practice safe, effective medicine, and then the potential for greater learning through the emotional salience of the experience. And so I'm going to share some quotes which illustrate some of our participants' reflection on that tension, harms and benefits. So in terms of harms to current patient care, one of our attendings said, I can't let residents communicate incorrectly with families because I think that undermines trust. And this idea of undermining trust via poor communication was widely viewed as an unacceptable harm. And it was funny, attendings were more apt to allow for other errors, medication errors, surgical errors, as opposed to communication errors, in fact. And I did want to share a few examples of allowed failure, which led to patient harm. So one attending shared that they didn't obtain a neck CT, which delayed surgical drainage by ENT of an absence by about 18 hours. And then there was a patient who required higher level of respiratory care. I think they needed BiPAP, but wasn't transferred to the ICU until the morning. And this discussion was happening around midnight. Significant psychological harm to the training was also viewed as a threat to learning and therefore a reason to not allow failure. One of our participants said it needs to be done in such a way that trainees' egos aren't harmed in the process. If they can't overcome the fact that their attending allowed a patient to be harmed for their benefit, they won't have the headspace to learn. Now, on the flip side, many participants talked about the benefits of allowing failure. They reasoned that allowing failure would benefit not only the trainees, but also trainees' future patients. I think this is one of my favorite quotes from this entire study. We need to stop thinking about patient safety only in the present tense. We need to recognize that our trainees will one day be responsible for thousands of patients once they graduate. I feel as though we have a huge responsibility to those patients as well. Now, the other benefit was on trainee learning. This participant said, when trainees do the right thing, there usually is not much emotion attached to that. And I question how much they actually remember and learn. So that's why I think it's so meaningful for them to fail and let things play themselves out. So as this quote suggests, participants connected the value of allowing failure to its emotional impact and perceiving those negative emotions, improved retrieval. They oftentimes viewed failure as a more powerful learning experience than succeeding. And our participants offered insights into attending's multi-step, though not always linear, approach to using failure as a teaching strategy. Now, this includes sort of 5 steps. The first was the setup or orientation. The second was the decision-making factors. And then you either had the allowance of a failure or not allowing failure or interrupting failure in some cases and conducting a debrief conversation afterwards. And just like before, I'm just going to share a few quotes which illustrate these insights. So in terms of setups, attendings commonly said that when they met with their team at the beginning of the week or beginning of a shift, they would have some sort of pre-scripted blurb around this. So at the start of my service week, I frame failure and mistakes as a learning opportunity. If you've already set up some of that environment, then I think it can be a lot easier to let trainees make mistakes. However, I think it's also important to note that none of our participants described how they would explicitly tell their trainees as part of their orientation script that they would be allowed to fail. So no one used the word failure at any point in these orientation scripts or orientation blurbs. And overall, participants talked about 5 factors that they would use or that would influence their decision to allow failure. So what was going on with the patient, what was going on with the trainee, what was going on with the team, institutional norms and cultures, and caregiver or parent-related factors. And I'm going to share some quotes mainly about the caregiver-related factors. Language barriers came up a lot. And a lot of the attendings were a little bit more apprehensive when a family's language of care was something other than English. So this participant said, with an interpreter involved, I would be worried that they wouldn't be able to interpret the nuances of what was going on. And also because I would be really concerned that the parents were thinking I was doing this solely because they spoke another language. So again, they were hesitant to do that. Now, some participants allowed failure regardless of whether or not the family was present, but others noted that the decision to allow failure was influenced by the presence of a family. So this participant said, if the family is in the room, for example, during rounds, I'm going to be worried about the parent and what burden and stress they're experiencing because I'm allowing this failure to happen. So sometimes they would have discussions outside the room or before rounds or after rounds when they would allow the failure to occur. Now, there were a number of stories or times that attendings described interrupting a failure. And these situations were characterized by higher patient acuity when stakes were a little bit higher, or if a patient was decompensating quickly, with quote unquote IC level patients or in a code situation, which I think makes sense. And the final aspect of our model was the debrief. Participants reflected on the content of these debrief sessions. This participant said, trainees know when they have messed up. It's like being called into the principal's office. You know when you're in trouble. So I don't find that there's any benefit in explicitly using the word failure. So again, just like with the orientation, our attendees didn't really use the word failure. Sometimes they would use error, sometimes they would use mishap, but they really tried to avoid the word failure because they felt that that just hit home too hard. Participants also talked about the ideal timing of these debriefs, with most participants preferring immediate debriefs. So this participant said, it's really stressful for a trainee to have to wait to speak with their attending after failure. I would never say, hey, let's chat about so-and-so tomorrow, because I bet they won't sleep well at night. So for the next few sets of slides, I'm going to talk about some learner, supervisor, and structural barriers. As I've talked about this and I've gotten feedback from trainees and colleagues at my institution across the country, around the world, I've sort of grouped barriers into these three buckets. And I think the first one is the learner level barriers, right? It's how do we do this where we're not harming learners' confidence? And I think the key is to really normalize things, to normalize failures, to set clear expectations early on. And this is a script that I oftentimes will say, you know, I too sucked. And that's why we do training, right? We do training, we do medical school, we do residency for a reason, because we're inherently kind of dumb. That's why we do it. Otherwise, we'd go straight from college to being attending. So it's part of the process. Another one of my favorite quotes is, anyone who's ever great at something once sucked at it. And I think it's important to continually normalize failures, not just the beginning of a rotation, the beginning of a shift, but to do it throughout the rotation for learners to really understand that you truly believe in this. In terms of supervisor level barriers that I've heard a lot is this pressure to role model perfection. And I know early on in my career, the last thing I wanted to do was admit failures in front of my colleagues, to admit failures in front of my trainees. I viewed it as sort of a sign of weakness. As I've gotten older, as I got promoted, I think it became easier. So I think it's important to call out the fact that there are professional norms that disincentivize this. But I think when possible, role modeling, sharing your own discomfort, sharing your own failures, not only when you are a trainee, but recent experience as an attending, is potentially an effective way to make this strategy work more effectively when you're doing it with learners. And then structural levels. I think I've gotten a lot of feedback, negative feedback about this from people from the patient safety world, and I think it's pretty legit, saying, how can you do this? You know, when I first proposed this study at my hospital, it took a long time to get it IRB approved. In fact, I had to meet with my vice dean of education. I had to meet with one of my bioethicists because they were worried. What if the Seattle Times gets wind of this? That there are doctors at Seattle Children's who are allowing failure on their patients. What would the press think? And I know when I was initially talking to Dr. Clausen back in 2017, 2018, when we were brainstorming next steps or projects, I threw out the potential of doing a study where we would interview patients themselves? Or what if we would interview parents and would let them know that there are some doctors who intentionally allow their trainees to fail on on them or their children? And her department chair at that time in Switzerland forbid her from doing that. She said, you would be fired if you did that. So we have not done that study. So this can be sort of a tricky topic. But as I said earlier, I think there's this dual obligation, right? It's yes, we need to protect the patients in front of us, absolutely. But we also need to prepare safe clinicians for unsupervised practice in the future. What better time, what better environment to allow some failures that don't have severe irreversible harm, to do it in a way where we can debrief, to where our learners can learn, so that when they do take care of their thousands, tens of thousands of patients as attending, they'll do it in a really safe way. Okay, so I wanted to conclude or end before we get to Q&A with one last opportunity for you to raise your hand or chime in. But I would love for the folks who maybe haven't used failure as a pedagogical tool or strategy to consider one thing. Is there something that you teach, whether it's a classroom situation, sim situation, rounds, emergency clinic, whatever, where you might be able to intentionally incorporate failure to enhance learner? Would love a volunteer to reflect and think about what they might be able to do moving forward.
Don't be shy with Jimmy. All right, Dr. Shah.
So great talk, and it was really interesting to think about your perspective of it's like deliberate failure in order to learn. I do a lot of work on the quality and safety side, and we think about how after a safety event, what are processes or things that we can do to help people reflect on what happened so that they take that as a learning moment and can use it as a way to help build resilience so they can go back to doing what they were doing. When I was thinking about this as you were speaking, I think a little bit of how we teach endoscopy. A lot of us, before we go into a case, will say to the fellow, I'm going to give you some guardrails. I want you, if it's appropriate, to have some degree of autonomy or independence, but I can't sort of let you struggle on a case for an hour, right? So I usually say, I'll let you sit in a spot for up to like 3 to 4 minutes if it's appropriate and the patient's stable. But at about 2 minutes, I'm going to prompt you and ask you to start telling me what you're feeling, what you're thinking, and what you're seeing, and verbalizing that. I'm not going to intervene, but I want to know what you're thinking. And then at about the 4 or 5 minute mark, I'll take the scope and I will tell you what I'm doing to get us unstuck. And so, in that way, we're using time as a little bit of a way to allow them to have some permissive failure. But I try to make sure that we at least talk through what they tried versus what I did so that it becomes more of a learning moment.
Yeah, I think there's so many great takeaways from what you just said, Dr. Shah. I think one is expectations, saying, I'm going to give you 5 minutes or 10 minutes or whatever it is for a given procedure is really key. And then you use the term guardrails, and that really resonates with me as well, because, I think about it like kicking a field goal, right? Like when you kick a field goal, you get 3 points if you kick it straight down the middle. You get 3 points if it bonks off the crossbar or one of the uprights. It doesn't matter. It all counts the same. I think in medicine, I think it's sort of analogous. There's multiple ways to do a procedure in your case, or to treat an infection. And as long as my trainees are within the uprights, I give them that autonomy. But you're right. But I do think it's really critical that we do give them guardrails. We can't allow them to kick the ball 20 feet to the right. That's not good for patients, and that's where I kind of draw the line. So I liked your sort of referencing the term guardrails. I think that's really important. And then anytime we can set those up a priori, I think can be beneficial. I think the literature on expectation setting is pretty clear that expectations are oftentimes the key to success, or the absence of setting expectation can result in sort of a negative experience for trainees. So thank you for sharing that example.